Well, our next presenter is going to be Sarah Veli-gold. Sarah is an Indigenous Australian disability researcher with familial connections to the northern New South Wales Kamilaroi lands. She completed her Masters of Physiotherapy at the Uni of Sydney and is currently working at St Vincent's Public Hospital and in disability research alongside Associate Professor Dr. John Gilroy. Over to you, Sarah.
Hello there. Sorry, is that working?
It is now, yep.
Oh, beautiful. Hello, everyone. Sorry, I'm just getting my screen up. That should. Oh, wrong one. There we go. Brilliant. So you should be seeing the first title there.
Yep.
Yep, wonderful. Thank you. Before I begin, I'd like to acknowledge and pay respects to the traditional owners of the land on which I'm presenting from today, the Dharawal Nation. As we share our own knowledge, teaching, learning, and research practices within this scope, may we also pay respect to the knowledge embedded forever within the Aboriginal custodianship of country. So as I was saying, my name's Sarah. I'm an new Indigenous disability researcher working with Dr. John Gilroy on the ARC project, and I'm also a part-time physiotherapist at St Vincent's Hospital. This paper started off as a 12-week research scholarship with Dr. Gilroy through Urangarang at Sydney University, and then turned into something so much more. So this is recently published paper in 2020, so not so recent anymore, and it was published by the Australian Institute of Aboriginal and Torres Strait Islander Studies. So today's paper is presenting to a hospital emergency analysis of clinical notes for Indigenous and non-Indigenous patients with traumatic brain injury in North Queensland. Traumatic brain injury is a major cause of death and disability for Indigenous people living in colonised nations. To date, no study has compared the incidence rate of traumatic brain injury between Indigenous and non-Indigenous Australians for any cause. And Australia's First Peoples, Aboriginal and Torres Strait Islander people are at least twice as have a higher rate of traumatic brain injury. Sorry, that slide moving across for you guys. Yep. Now, this study, as I said before, this paper was published as part of a much larger NHMRC funded study describing the experiences of Aboriginal and traumatic brain injury patients returning to the community following discharge from hospital in Northern Australia. They did this by de-identifying patient emergency department presentation data for the Northern Queensland region and was obtained from Queensland Health for the period of January 2007 to 2015 inclusively. So the approval to use this patient data was also obtained under the Queensland Public Health Act. And this approach allowed us to access and analyse routinely collected patient data, de-identified of course, without the requirement of explicit patient consent. Oops, sorry. Data was provided for 3,114 ED presentations by patients aged between 15 to 65 years with a primary diagnosis of intracranial injury. From this, it was further separated into Indigenous presentations and non-Indigenous presentations. Unfortunately, 47 records, so 1.5% roughly, was unknown Indigenous status, whether they've chosen not to declare what their status was, and were excluded from the current analysis. This created a data set of 3,067 ED presentations, 671 were Indigenous presentations, and 2,396 were non-Indigenous presentations. As this was over a 9-year period of observation, in order to conduct a meaningful and manageable comparison, a sample of 671 non-Indigenous presentations was selected from that 2,396. And then this selection was undertaken by grouping presentations by year and then randomly selecting an equal proportion from each year to produce a data set of 1,342. This approach ensured a balanced and appropriate comparison of the records of patients attending the ED, the emergency department, with a traumatic brain injury at points in time, namely the same year. And this was relevant to understand the risks and circumstances experienced in the broader community, and they'd likely be similar across the page. There were 54 Indigenous records with no information in the clinical notes, so hadn't been filled in, or they may have left without being treated, as well as 58 from non-Indigenous records with the same level of missing information. So we had to exclude those as we didn't have enough information to analyse. So 607, that left us with 617 Indigenous presentations to the emergency department and 613 non-Indigenous clinical notes to analyse for the thematic analysis. This research, as I was saying, was led by myself and Dr. John Gilroy, who identify as Indigenous scholars, and we adopted the principles of Indigenous standpoint theory. This allowed us to use the knowledge and values obtained from our own cultural heritage simultaneously with Western frameworks of research during data collection and analysis. We also had a lot of fun using NVivo software for that thematic analysis. As I was saying before, there was actually, when we talk about the clinical notes, it's not just one note that was what we went off. We had to use 3 different types of notes. So there were clinical notes for the thematic analysis. The first one was the information provided by the triage nurse on duty. This information included the medical history, the ascertained injury type, clinical screening, observations undertaken, and a short background of the incident that led to the injury, the traumatic brain injury. The second was the treating doctor's description of the presenting symptoms or complaints. And the third type was descriptive information recorded by other clinical staff involved in the patient's care, whether that's the allied health physician or possibly a treating consultant who came down to see them while they were in the emergency department. So that draws back to what I was saying before. If they didn't have all 3 of these notes, they were excluded from the study, and that's where we got our sample size from. I think it's also important to note that from our analysis of patient presentations, sometimes we found more than one reoccurring theme within that same clinical note. So I'll touch on that in a second. So for example, the quotes, some of the quotes have included here from the ED presentation. As you can see, the first one, it says injury, As you can see from the first one, it says injury, and it has blunt injury post alleged assault by partner. So this is an example of one that we would include in the domestic violence category. Then the second one has alleged assault by nephew and brother, and that's what we would include in the family violence category that contributed to the traumatic brain injury. But also it had ETOH. For those that aren't aware, ETOH is the medical abbreviation for alcohol. So there was alcohol consumption as well. So that would have come across as 2 different themes. And the third one would be pedestrian hit by a car. So that would be a traffic incident. And ETOH++ just means that they were intoxicated at the time. So they're just a few examples of the ED presentations that we had. And from that data, we were able to see that some of the recurring trends and patterns of Indigenous traumatic brain injury presentations, and what was causing them to come in was accidents and mishaps, traffic incidents, seizures, sports, police involvement, non-compliance and or aggression, and unfortunately alcohol and assault. Sorry. My apologies, it wouldn't be a post-pandemic in-service without a bit of technical difficulties. Here we are. So it should be the table that's presented up on at the moment. So identifying trends and patterns of traumatic brain injury amongst Indigenous Australians. These are our result findings. So this table is showing the frequency of the occurrence of these themes recorded in the notes of included patient records. And as I said before, there were more than one theme possible for each patient, as you saw in those previous quotes. The main key findings I want to draw attention to is that alcohol and assault played a significant role in the presentations to the emergency department for traumatic brain injury amongst young Indigenous people. Indigenous people were twice as likely to be involved in alcohol consumption than non-Indigenous people who presented with traumatic brain injury, and presentations that involved assaults were highly common amongst the Indigenous population in the background of alcohol consumption. Family violence, as defined by the Australian government, is violence occurring within the family and kinship dynamics with the exclusion of domestic violence. Family violence was less commonly reported in hospital presentations than domestic violence for both patient groups. However, family violence was more prevalent as the cause of injury for Indigenous patients than non-Indigenous patients presenting with traumatic brain injury. From the data, Indigenous female patients had a higher rate of presentation due to domestic violence at 64% than Indigenous males at 36%. In contrast, the rates of non-Indigenous domestic violence cases were similar between male and female, being 43 and 57% respectively. Accidents were responsible for almost double the number of non-Indigenous patient traumatic brain injury presentations to the ED compared to Indigenous patients, and that included like work health and safety incidences. Alcohol involvement in traffic incidents was more frequently reported in the non-Indigenous patient notes, and they were more likely, non-Indigenous patients were more likely to be involved in MVA and so motor vehicle accidents and motorbike accidents, whereas alcohol involvement and traffic incidents saw that more Indigenous presentations as pedestrians being hit by a car. The combination of alcohol consumption and aggression and or non-compliance was evidence in both Indigenous and non-Indigenous patient clinical notes. And for anyone who's worked in the hospital setting, it should be as no surprise that alcohol involvement was recorded in almost half of the hospital presentations of non-compliance and aggression towards healthcare staff for both population groups. Indigenous male patients under the age of 18 were most commonly presented with sport injuries, and also noted that they had multiple admissions for the same injury. From the clinical notes, there were no one common factor associated with seizures. However, there were more presentations of alcohol-related withdrawal seizures amongst the Indigenous population than non-Indigenous. So that's just a quick overhaul of all the findings. In conclusion, I think the study presents the findings of the analysis of the emergency department clinical notes of traumatic brain injury patients in Northern Queensland. These notes do not voice the experiences of traumatic brain injury patients, and I think it's important to remember that. This paper aimed to identify the themes in the clinical notes of Indigenous and non-Indigenous people presenting with traumatic brain injury to ED in Northern Queensland. The findings from this study have implications for policy and practice under the Closing the Gap strategy. Thank you, everyone, for listening. And here are some references.
Yeah. So there's a lot there, and great information, actually.
Thank you.
But it does show that we can't just compartmentalise any of our issues of chronic diseases, and that there are other elements to it. So we look at it from the determinants perspective, and how they're all interrelated. And anyhow, that's just my 2 bobs worth. Any questions have come up?
There aren't any, but I have one. And I was just wondering, Sarah, about whether or not you can ever evaluate or record assumptions made about alcohol intake, because we do know kind of anecdotally that often when Indigenous people present to places like ED, there might be an assumption of alcohol consumption, according to whatever they're presenting with.
Yeah, definitely. As an emergency department physiotherapist, I do understand that completely. A lot of the clinical notes with the observations taken by the nursing staff, it did include a BAC for a lot of those patients as well. So that was something to be considered of in the notes.
So BAC, is that a physical measurement of alcohol? Sorry.
It's a blood alcohol take, yeah. But that was also, I will be honest, in some of those notes, it just said ETOH++, but then generally when it was quite high, they would take a BAC. For the ones that just said query ETOH, I didn't include those in that overall, because I didn't think it would be fair to say that distinguishing factor.
Yeah, okay.
Yeah.
Great. Thank you.
No worries. Thanks, guys.
Excellent.